So clinically, I'm an ER doc, still practicing at a level 2 trauma center, which means I work in a place that is the junction of all failure in healthcare. When your mama wants you, when the police don't need you, and your bar tab is full, there's the ER. And it's the one thing that universally all of healthcare can agree there's absolutely no value in the ER. So if we could just eliminate the ER, we would be saving money. So with that in mind, you'll understand why I work on value-based purchasing, because everyone tells us that we are the failure and that technology will solve the day. So my story goes back to the beginning of this ancient technology many of you may not have used in your lifetime called the fax machine. I still use it every day in my job, which is a testament to where technology is in healthcare. We're all here talking about the exciting world of AI on the right. I'm going to posit to you that in fact, the fax machine is probably better than most of the AI technology here, and I've probably just offended half of you. And the reason I'm going to say that is that one of the axioms, I think, is that people innovating in healthcare think of the sleek and sexy and not the simple. And as an ER doctor, we operate on a very simple principle. Keep it simple, stupid. The simplest solution is always the easiest. And so my initiation of value-based purchasing began in the Great Recession. I came out as a young resident. The healthcare authority who administers Medicaid in Washington State said, we've got a budgetary problem. We want to make value improvements. They used all the key buzzwords, right? Since the beginning days. We're going to improve value by not paying for unnecessary care. Sounds brilliant. Everybody in this room would love that. Our solution, though, is we're just not going to pay the bill for things that we deem to be non-emergent. What's actually driving value or just reducing cost? I posit to you it's actually just reducing cost. And we're going to label things like chest pain, miscarriage, and seizure as non-emergent conditions and just stop paying the bill. Not exactly a great idea. So being a young, foolhardy 26-year-old ER doc, I'm like, we can take on the state and fight. And so we did. And we went to them and said, really, what is the problem that you're solving? Because I think that's the first question. We need to ask the right question. At an emotional level, their answer was, we have a $74 million hole in our budget. We have to fill a hole in the budget. What they were spiritually saying was, we actually want to make better healthcare. We want to do better. We think that there is waste happening in the system. Now, they assigned that to the ER doctors, and we said no. Fundamentally, the healthcare system today and then operates exactly as it is designed. The reason people come to see me in the ER today is because they can't get in to see their primary care doctor. They can't get into an urgent care because they're not open past 8 o'clock. And most people are working, taking care of their families, or doing other things. They put off their own health till the end. So the system today still continues to work that way. So we think we can actually fix the fragmented healthcare system. We can make this easier with a simple solution. And what we did to drive value was what we call the 7 best practices, but boiled down to 3 points. We took the admission, discharge, and transfer feed from every hospital. Remember, this is 2009, before Epic was really taken off. There was still 74,000 different EMRs in the environment. We're down to what, 50, give or take, with 2 big winners right now. And we said we're also going to do guidelines. And with that information alone, I can reduce the utilization of healthcare in the emergency departments in Washington State. And by the way, we'll implement this in 95 hospitals at the time in about 80 different health systems in 3 months. And they laughed. We said, well, we can do this because we don't need every data point, but I, as a practicing ER doctor at St. Joseph's, need to know if you've been 6 blocks down the road at multi-care that has a different EHR that I can't see, because it changes the conversation. It changes what's going on in the world. And then we're going to give you simple data feedback about what your utilization is and whether or not you're complying with guidelines that we all agree. We're not going to refill methadone. We're not going to refill chronic opioids. We are going to do opioids as the last tool in the toolbox, as we say, not the first tool. Simple rules to follow. And in our first year, we saw dramatic results. 10% reduction in ED visits by all Medicaid clients. Simple data, and the trend continues. We saw 10% reduction in our high utilizers, which were the ones that were defined as more than 5 per year. And amazingly, we saw dramatic reductions in our opioid prescribing, 24% in the first year among this population. And some of you say, well, how is that possible? What was the technological innovation? It was the fax machine. Honest to God, there were faxes that came in on yellow sheets of paper, and all they did was organize the data in a useful way. It said where you were, what controlled prescriptions you got, and whether or not you got a care guideline. All in a fax machine. How many Medicaid directors today and health systems would kill to get a reduction of 10% in their ED utilization in a year? All through simple solutions. Not Gen AI, not anything like that. And so I look at healthcare in that way. I think all of our technology is really cool, but I think we also need to think about what is the simplistic and easy information that will drive actual change in healthcare. What is it that I, as an ER doctor, sitting in the box, need to know about you when I walk in and say, "Hi, Mr. Jones, you're here for chest pain." I need to know a lot of details that I can't quickly get, no matter how good Haiku is on this thing, to know where the direction is going, what the story is about you. How long have you been here? Have you had a cardiac cath? Have you had a PE in the past? Do you have a prothrombotic state that would push you at risk for blood clots? Do you have uncontrolled hypertension dating back years? I should be worried about an aortic dissection. Did you recently have COVID that could change your story? Are you on immunosuppressants that put you at more risk for infection? Those are the data points I need. They're few, they're simple, but even the AI summarization that's out there is going to pull a lot of other stuff. So as I look at it, we need to get data that is useful and then drives clinician behavior through simple exchange. And we've continued the trend that we started a decade ago and expanded it now with opioid prescribing in Washington. To this day, I still serve as the chief clinical officer for the program, of just giving clinicians simple data. That's the sheet you get on the right-hand side that says where your opioid prescribing is compared to your peers. No heavy hand, just some random ER doc in the state sending you data about your performance compared to your peers. And when we started, 20% of opioids were above guidelines in Washington state. And today we're down to 5%. Nothing more, no heavy-handed, no medical boards coming in and threatening your license. Just data and information that is actionable and is fair to you, and also has somebody you can interact with at the end of it, a human in the loop for the technology. And so at the bottom is my email address that they can still email me, and I have conversations every month with clinicians about their data and how to change it. So I think when we look at value-based purchasing from a healthcare perspective, to be honest, they're kind of like most modern grocers. Why can't you just bag your own groceries? You'll save us money, you'll save us time. Why, doctors, can't we just do HCC coding? Right? It's the modern equivalent. We like to stand back and have one security guard watch you do your own work rather than doing the coding for you as professionals, because you can figure it out. You can find the barcode on the green beans yourself. You can figure out the code to type in on the tomato. I see some of you wincing going, yeah, I've got it all been there, sitting on a little scale. But doctors fundamentally don't care, right? And we see it in the grocery industry. If you go and look at the data, most grocers sell more carrots than they buy. Why is that? Because that's the easiest code to find, and so people just push carrots because they're sick and tired of searching for the little code. We've automated and generated technology that in theory improves our world, but actually increases their loss because everybody's just buying carrots, which are also very cheap in bulk. The same thing is happening in healthcare when it comes to this. So I think, again, we've got to ask the question, why are doctors not doing HCC coding? Well, we're not coders, right? And the system is not designed to work for us. If I want to put in a finger fracture to specify the level of a boxer's fracture of the fourth digit, closed, non-displaced, non-angulated, there are about 200 codes conservatively. Epic's interface is not designed for ease, because if you type in boxer's fracture, it won't pull up that specific fracture. It'll say, sorry, no query generated. It's like, do I care as a clinician? As an old ER doctor writing on a physical note, I wrote boxer's fracture. That was it. Done. End of the conversation. I didn't have to argue with an electronic record to get the right thing. And now you're saying not only do I have to argue with it to find a code, you want me to argue to find a code that matters to you and not to me. And I'm already spending 50% of my day in front of this blessed machine, not interacting with humans, which is what I came here to do. Yeah, right. Good luck. And by the way, the solutions we have are, don't worry, we've got really easy courses for you to take. You can become a coding expert too. Isn't that what you want to do with your CME dollars? Not learn about, changes in medicine. You want to become a better coder. Sorry, I don't think that's a good selling point. So what we're building right now in Providence in our MedPearl platform is actually a way to make it simple. And then we will actually surface the HCC codes potentially for you with automation. And there are a number of groups doing this out there. And I think that's critically important. And we're integrating with the clinical decision support so that when you go to get knowledge about a clinical condition, you can also get knowledge about the code in a very simple manner that doesn't intrude upon your daily practice. Hopefully gets you the information you want. Is it going to be perfect? Is it going to solve everything? Of course not. But it's an incremental change that slowly helps you become a better clinician, not by spending 50 hours with a coder, but by saying, hey, when you're thinking diabetes, think of this code. Remember to include the complication, because that changes the HCC weighting, it changes your RAF score, it can change your inpatient CMI admissions, it can drive the reimbursement in the long run that in theory, the health system's gonna share with you. I stress the words in theory on that statement. And we've done this with simple interventions. This is a program I ran at my prior health system where all we did was surface the HCCs that were relevant. And we were able to drive quality improvement in actually 1 month, month to month, but we're able to sustain it over the year from 20 to 80th percentile. Now, does anybody believe we actually changed clinical medicine? No, we changed the capture rate. And so when I talk to clinicians about this, I say the reason you should care about this is because you're already doing good quality medicine. We're not capturing it. So I know that looking at the bottom of that thing and making sure to type in diabetes complications is irritating to you. We've surfaced it in a simple way for you that's relevant to the patient in front of you, that is real-time education. And if you'll just do this little thing, we, your overlords, will make sure that your quality data reflects the quality work that you're doing. Because it's not fair that you're getting labeled with a leapfrog grade C, because you're doing A work. And that simple innovation, I left my prior health system a year ago. Just last week, I announced that all of their hospitals hit A grades in the division on leapfrog. And a lot of it is because of changing the quality capture and getting a culture that says, we're gonna make it easy for you. We're gonna do the hard work and the lift. We just need you to take that one last step to do it. From the payer's perspective, they really want to pay for quality, not quantity, right? That's the transition we're all trying to make. And we're gonna watch you, and we promise, we'll make it better. We're here to help. We're the insurers. I'm gonna argue again, they're not always asking the right questions. Because their simple answer is, well, why are you doing a repeat CT? Why are you doing that repeat test? What is it that you're doing? Why are you making my life harder? Why are you billing for an exam? Well, again, if I don't know that you've been in another health system, how am I supposed to know that you had a CT? And maybe you're getting multiple CTs because you have a small bowel obstruction and you're currently having one, and we have to diagnose that every time and know whether or not it's a surgical emergency or medical treatment. Is your data acquisition also correct? So United Healthcare, and I pick on them because they really sent me this letter, said, hey, Dr. Schlicher, your group is ordering too many chest CTs for pulmonary rule-out. And being an inquisitive human, I wrote back and said, really, what data set are you using for this? Well, we reviewed claims and looked at it. Okay, how many patients did you look at? We looked at 278 patients. In my hospital? Oh no, across the country. Okay, well, how many were from my hospital? Well, from west of the Mississippi, we had 107 patients. Well, again, how many were from my hospital? Oh, well, actually, we don't have any from your hospital or your group. So you send me a letter saying I'm doing bad medicine as an ER doctor, ordering too many chest CTs based upon exactly 0 patients from my hospital or even from me. We're actually driving quality. Recently, in the last few years, there was an attempt to do chest CTs for ACS because we didn't want to pay for observation codes and we didn't want to pay for admissions. Well, we'll just radiate everyone. Well, who's most likely to get a chest CT? Generally, they're younger patients in their 40s and 50s that are getting these chest CTAs for coronary rule-outs, often women. And so it's a very large dose of radiation to an angiogram of the heart. And imagine what's getting radiated in the box. There's some radiosensitive things there, especially in young women and even young men. Breast tissue, ovaries, thyroid, some backscatter radiation into your cornea. So are we actually driving quality improvement in healthcare by encouraging the use of additional radiation and ionizing radiation when we could instead observe you, put you on a little treadmill and have you walk or run? That has the greatest risk of you falling and breaking your hip maybe? So I'm going to advocate we got to ask the right questions. And so this is the other piece we've been building is trying to get the right data in front of the clinician in a rapid manner, what we call auto-contextualization. And in this, we're trying to surface that prior information because again, I have a few moments in the room with you to know what I want to do with you. I don't have time to read the modern epic record for most of my patients that probably is longer than War and Peace. The Encyclopedia Britannica has less information in it than the modern epic record for a 76-year-old diabetic with hypertensive hyperlipidemic disease. And you want me to go through and find a cath report that when I search for it and type cath into the little magnifying glass, pulls up every time the word cath has been involved, including your Foley catheter. And every time you reference that you've got a catheterization done back in 2011, and my eyeballs start to bleed trying to find the stinking cath report. Whereas what we can do is say, oh, you're in for chest pain, and pull up your cath report, your last echo, your troponins, your EKG, and your last stress test. And then all of a sudden, I've got a very different picture about who you are as a patient in front of me. It's not about getting all data, it's about getting the right data to the clinical situation. And so if we can make the EMR smarter that way and give specific inferences and specific education information, not just generic statements, I think we can actually transform healthcare, and this is what we're starting to see. You know, I played with some of the tools with some of the other vendors at a conference recently, and I typed in, does a 65-year-old man on Coumadin who falls and hits his head and lose consciousness need a head CT? And I think all of you would go, yeah. Even if you're not clinically, you'd be like, that's a blood thinner. Hitting your head and losing consciousness is bad, right? We can all agree on that one. And the AI spits out, you know, beautiful page-long summary. Scoring guidelines are often useful in this situation. If the patient's still confused at 24 hours, we recommend follow-up CT, and so on and so on and so on, generic information. Not actually just a straightforward answer. Yes, based upon the guidelines, you should get a head CT. If you can't answer that yes, no question, the technology is not there yet. So what can we do in the interview space to keep it simple and bring the right data and the right rules to folks? And so that's what we're building inside of MedPearl, and really being able to see that. We're seeing that improvement. By getting the right guidelines in front of folks, we've been able to reduce our referrals for our urgent care providers so they don't have to go to a higher level of care or take up our specialist time. We've also done evaluations of what our people perceive their quality improvement is, and 80% say that using the tool has actually improved the quality of care that they're delivering. So they feel better about the medicine they're doing, because in that busy environment, they don't feel like they're stumbling along as quick as they can go and maybe missing something. And their pajama time has been cut down. Ask any doctor what they care about. It's how much charting do I have to go home and do and be away from my kids. Most of my colleagues have a spot in their kitchen where they have a computer set up so that they can be writing their notes while their kids are playing. I think that's a very sad testament to modern medicine. No one else really cares in the health system about it, but the docs do, and the NPs and PAs and others doing their work at home. And by the way, we improved our view collection so that they're actually bringing in more revenue to the health system while spending less time doing it. So when I think about how we look at value-based purchasing, I know your opening act for the rest of the day, you're going to hear a lot of cool solutions, but I always go back to keep it simple. What can we do that are simple innovations that make marginal changes? Complex solutions may be the eventual final answer, but most of them are not fully baked yet. And when you put them in front of a clinician and say, play with this toy that's going to take me more time and interrupt my workflow, you're not going to make friends. And the greatest way to derail your deployment of a device is to piss off the people that you want to use it, right? I think we can all agree on that one. And clinicians will generally give you one bite at the apple. And so as we look at deploying these solutions, we need to be thoughtful about what is the simple solution that is straightforward, what is clinically accurate and makes better care, not just does faster care, and works for both the patient, but also the clinician that's doing it. And the more we can have clinicians delivering that message, and it's not just because I'm one of those people, but the more we get clinicians saying, hey, as a fellow doc, this is something that improves my practice and is clinically accurate, the messenger matters. And so I encourage also, my colleagues that are, interested in this space to come join us in the innovation world, because I think it's critically important that we're helping build the plane as it's being flown as clinicians.